So thank you everyone for being here today in this interesting session regarding how can AI add value to neuro-radiologists' workflow. And because of time, I think it's time to start actually. And I will start with you, George. So how can AI help healthcare providers better manage acute stroke patients?
Great, thank you very much, and thank you for the invitation to speak today. When you think about stroke and adding value to the stroke care, we need to think about where the biggest unmet need is in stroke. Stroke is a massively undertreated, under-recognized condition worldwide. Even in developed countries like the US, huge swathes of people go untreated or inappropriately treated. And what we do is really focus on that unmet need and where we can add the most value. So if we start off thinking about what happens with a stroke patient, they typically go to their local hospital, a non-specialist center. What does that mean? Well, it means that the hospital doesn't have access in the ER to advanced imaging such as CT perfusion or MRI. It'll just be a non-contrast CT, hopefully with a CTA, but sometimes even that can be challenging to get in a timely manner. And of course, they also lack that specialist expertise to interpret and to drive the treatment decisions that are essential to improving patient outcome after stroke. So what we do at Brainomix is really focus on that unmet need. We provide a suite of AI-driven tools to process all acute stroke imaging. Not just CT perfusion and MRI, which we do, and I think we have very good technology for that, but really doubling down on the value we can extract from simple imaging, such as a plain non-contrast CT scan and a CT angiogram. And so what our technology does is it processes those scans in real time, fully automated, and outputs the results to all the key stakeholders you need to know. Now, of course, that's the radiology team, but also the stroke physicians who are interpreting the scans and making treatment decisions based on those. And so what we do with those imaging modalities is we try and identify patients for treatment, flag them up with patients with suspected stroke, and focusing really on the simple, accessible imaging. So the non-contrast CT, we can identify patients even without any contrast who have a suspected large vessel occlusion. We use evidence from early ischemic change, hyperdense vessel sign, and combining those imaging biomarkers, we flag patients with a suspected large vessel occlusion who need timely treatment. Of course, we also do that on CT angiography, and then critically, we get more information out of the scan, which can be very hard for physicians to do. We can identify the extent of ischemic injury, and again, just on a non-contrast CT scan, we can identify, for example, the ischemic core region, giving doctors of all specialty information about the extent of injury. So when you're making risk and benefit decisions about treatment, you have more information to hand. And historically, that was only possible using, for example, a perfusion scan or an MRI. And we know that those are not easy to come by in your typical critical access hospitals or primary stroke centers. But using our technology, we can now make that information available to all physicians so that we can make better and more timely treatment decisions about stroke. And the effect is that when we put our technology in, is that we see more patients being treated, the right patients being treated, and better patient outcomes. Brainomix, we're very excited to be entering the US in this last year. We're market leaders in Europe, and we've seen some transformational results in Europe, with many more patients being treated in a more efficient and timely manner. So not only are patients getting the right treatment, they're getting it quicker. Every minute that goes by when you have a stroke, you lose 2 million neurons on average. And so time is of the essence in getting these patients treated, and it's been really gratifying to see the opportunity to improve the way that stroke care is delivered in Europe, and now we're starting to see that traction and moving the needle in the US and other parts of the world as well. So in summary, I think the key is identifying where the biggest unmet need is, the biggest opportunity to add value to patient care, to add value to that imaging workflow in stroke, ultimately leads to better outcomes for patients.
Wonderful, and thank you for that comprehensive answer. I will continue with you, Roland. I want to ask you, how can the proprietary imaging biomarkers related to microvascular and oxygen metabolism be utilized for stroke management and neuro-oncology?
Thank you for the question. So what we do at Cercare is that we use our technology to extract known but also new imaging biomarkers from the standard clinical data. I think we all know it's extremely difficult to change how patients are imaged, right? It's highly embedded with the device manufacturers. So we use the data that people already have, so they can also test our technology always on retrospective data, and use our technology to extract the data that they need, for example, for parametric maps, for stroke and oncological workflows, with a higher quality, so they have less noise, so they have sense already a new, better, improved product. And in addition, we extract proprietary markers related to microvascular health, so capillary transit time, heterogeneity, and also we model oxygen metabolism from, for example, standard gadolinium scans. So we model this. This is also done without AI, so it's fully deterministic. So when you do it multiple times, it's the same. And the information of these markers, you can either combine them with the ones that already exist, like CBV, for example, in oncology, to become more specific and have additional information. Or we have also several recent publications that show that they can be used on their own and outperform markers like CBV, for example. So there's different ways that different hospitals, large or small, can invest this new information in either providing more detailed diagnosis in difficult cases, or just use it as a quick triaging tool to very quickly separate unchanged or normal scans from abnormal scans. So it can also very much be used to improve the workflow and save time. And more specifically, so for stroke, for example, our cerebral metabolic rate of oxygen maps have been used to provide a much better definition of the core, which can be very difficult to determine. And also our OEF, so oxygen extraction fraction maps from standard perfusion series. They have been shown to predict the reversibility of ischemic lesions after thrombectomy. So you have, at a visual glance, a predictive marker for how lesions can respond to thrombectomy. So this was recently published in Stroke last month. For oncology, I think one of the main uses that we have seen is that people can use our high-quality CBV maps together with the cerebral metabolic rate of oxygen maps, the oxygen extraction fraction maps, and the capillary transit time heterogeneity, again, which says something about microvascular health. So this is information which is usually lost in standard processing techniques on other platforms. You can use that to much better separate progression and pseudo-progression visually. Or again, if you just want to use one map, not all radiologists want more information. Sometimes they want more condensed information. You can do that, for example, with CMRO2 maps, which also have been shown to outperform CBV. So there's different ways the new biomarkers and the improved quality maps can be used that are output by our technology.
Perfect. Thank you so much for the answer. Now, well, 1 second, internet situation. I will continue with you, Michael, from Imaging Biometrics. I would like to ask you that you have different MRI imaging sequences to support the evaluation of brain tumors. Can you tell us about how they can add value to neuro-radiologists today?
Sure, thank you. Love being here and love to tell you about our imaging solutions. So one of the consistent pain points we hear from neuroradiologists is the ability to distinguish between tumor and treatment effect on conventional imaging. As you know, the contrast enhancing region is can mimic both tumor and treatment effects, so you got to be able to distinguish between the two. It's critical that you get that answer to that question right. And yet we know that RANO criteria and other response assessment criteria rely on contrast enhanced imaging, which is, again, limited. So the only true way to confirm what's going on aside of imaging is to obtain an invasive surgical biopsy, which nobody wants to have. So we have created two unique tools. They're both quantitative and automated. The first one is a delta T1 map. Those are maps that can identify the subtle regions of contrast enhancement much better and more objectively than the human eye. And it also subtracts out confounding factors such as post-surgical blood product. So what you're left with is a true region of contrast enhancement. And then within that region, we then use our IB Neuro, which is an MR dynamic susceptibility contrast enhanced technology to calculate quantitative or standardized RCBV values. So multiple groups have done carefully analysis using biopsy samples correlated with our imaging results, and we have validated that we are able to distinguish between tumor and pseudoprogression or treatment response. So within that enhancing region, we calculate the RCBV values, and then we can create what's called fractional tumor burden maps. And those maps are quantitative, so you can actually track the changes of volumes over time as the patient undergoes various treatment therapies. So it's really critical to show much sooner and more accurately whether a patient's responded to treatment, because in honesty, these brain tumor patients don't have a lot of time, so to spend 2 or 3 months on the suboptimal treatment plan is not good. So to bring it all together, we also have a third application called IV Nimble. IV Nimble is a handheld mobile app that enables secure and real-time collaboration with multidisciplinary specialists. It's driven by algorithms, and it can be customized per site. So we have multiple sites using it now for metastatic brain tumors, and so that's just a good way to harness all the information that's available to these multidisciplinary teams.
Thank you so much for your answer, Michael. I will continue with Sinan, and I would like to ask you, reimbursement is an incentive for AI adoption. Could you explain how CPT III codes for brain volumetric application can help drive adoption of these products?
Sure, thanks Juan, and thanks for the invitation for the panel. So maybe just for context, when we're talking about brain quantification solutions, we're of course talking about the ability to identify, characterize, quantify, and track abnormalities in brain MRI sequences like T2 flare, looking at hyperintensities, or in T1 sequences looking at the atrophy of different structures and regions of interest, comparison with normative populations, and tracking in time comparing to previous visits. And what we see through the use of these types of solutions is that really the radiologist plus AI is becoming standard of care. And what we unfortunately see at the moment is that there's still a lot of radiologists and therefore patients that don't have access to the benefits that these AI solutions bring. So there are a number of barriers to adoption of these types of solutions, and reimbursement would be a very important barrier. How can we overcome it? Well, first of all, we have to understand why reimbursement is so important. Well, the healthcare provider needs to establish the medico-economic benefit of using the solutions and the return on investment that comes with them. And at the moment, it's up to the healthcare provider to do that, or they work with the AI vendors to put in place trials or studies to support the financing of AI solutions. And that's where reimbursement would come in, because it would remove this barrier to adoption. And the CPT III code that has been put in place is an important first step, I think, in the resolution of this challenge. It allows us to gather real-world data to justify the medico-economic benefit of these types of solutions. And I think it's a promising time where there's a lot of confidence in this field at the moment, because even without the reimbursement, we see an exponential growth in the use of these types of solutions. The feedback that we're getting from our clients, our users, is extremely positive, and it's attesting to the benefits that this type of solution brings, both in a clinical nature, being able to detect earlier any patterns of atrophy that might be relevant for diagnosis and patient follow-up. I mean, we've put in place studies showing that enhanced detection rates of up to 28%. We have reduced radiology reading times of up to 65%. And that's not even to talk about the more qualitative aspects of these types of solutions, where we get radiologists coming back to us and saying that they really appreciate the level of confidence that this provides in their radiology reporting. and therefore the peace of mind that they have at the end of the day. So for all of these reasons, I think it's a really positive time, a really exciting time to be working in this field, and I think that the establishment of the CPT III code is really a landmark moment, and shows that we're on the right path, and the future looks bright.
Thank you so much. And I just want to grab something that you mentioned, that this is a really exciting time. We're starting to see an almost exponential increase in the available solution and in the use of these solutions in clinical practice. And for all of us that are here, I think that is actually what move us and what have us here. So again, thank you so much to the fourth of you for being here. I think that we have a few minutes more, maybe 2 minutes. I don't know if you have any final remarks or ideas that you want to share with the team before we close this session. It's not mandatory, so it's only if there's any idea, not pressure.
I could maybe just give a quick nod to Blackford, maybe, because we were talking about the barriers to adoption, and I think one important barrier to adoption that Blackford is really helping to solve is the integration into the hospital environment. And we think, particularly in America, I think it's one of those aspects that is very difficult to solve on your own as an AI vendor, and having the mutualizing, I suppose, the resources and having the support of Blackford, I think is an important help in the mission towards AI adoption. Yeah.
Anyone else?
Yeah, I was going to say it's interesting reflecting when we talk about the adoption and use of AI. We've now got to the stage in stroke, at least, where AI technology is now recommended. So it's no longer a sort of nice to have early adopters playing around with neat innovation. Actually, it's seen as a standard of care now. So I think what's interesting is we're changing the conversation from should I use AI technology to which AI technology should I use, which I think is really interesting. And I think that's the sort of the next conversations that we're having in the next few years will be about that. And also, which direction is it going in? You know, how can we add more and more and more value to our healthcare workflows?
Perfect. Thank you so much. Okay, so if there's any other comment, thank you so much for being here. Enjoy the Congress and have a nice day.